you very much. It's a great pleasure to be with you in Baltimore, and we'll plan to do 3 cases today. The first one during this session on bifurcation, and this case will be a bifurcation, of course. The next case will be a valve, a percutaneous aortic valve implantation, and the last one will be a left main case. So let's start with the first case with Philippe Garot, Marie-Claude Maurice, and everybody in the class lab.
Dr. Farge as an anesthetist.
And Marie-Stella as a nurse.
And Thierry as nurses.
So can we have the story of the patient?
Okay, so our first patient story is as follows. Next slide, please. It's a male of 74 years old who had recently exertional angina. His risk factors are hypertension, diabetes, hyperlipidemia, and he had in 2000 mechanical aortic valve implantation that makes that he is on warfarin since that period. He's in sinusal rhythm. He has ischemia demonstrated in 2 territories, in anterior and inferior, and the lesion that explained so he has valve and no graft, and the lesion that you see there is the one that we will treat today, LAD bifurcation, LAD diagonal bifurcation lesion. He had also ischemia in inferior because of lesion on the right coronary, which was, let's say, diffusely diseased, but had 2 focal, very tight stenosis that were stented 2 weeks ago. Next. Okay, with this result, which is not perfect, it's diffuse disease, but there is no more focal stenosis. Next. Okay, so can we see the live image? Okay.
So we saw that the patient had diffuse right coronary disease that was treated with the 2 drug-eluting stents and has calcified mid-LAD stenosis involving a large diagonal branch as well as LAD.
Yeah.
This is going to be quite a challenge. It's going to be difficult to wire the side branch, and if you plan to perform a atherectomy of the main vessel, and then it can also be quite challenging. But let's ask our panel here to see how they would approach it. Charlie?
In the meantime, while you are discussing, maybe we can show the 3D reconstruction that was done with the Pion system that you see there, which is for us helpful in calculating both orientation, ideal angle for wiring, length and diameter of the stents. And okay, show the length, for example. Okay, you see it's very precise, it's very helpful. But I'm sorry I interrupt you. You can go on with the discussion, and we will put the why during that time.
That'd be great.
Okay, and just a brief comment, Marie-Claude. This is Chuck Simonton.
Hello.
This is a really great case. Can you explain how the 3D reconstruction is done for the audience?
Yes, we have to make 2 views. 2 views with more than 30 degrees of difference each, and then the 3D reconstruction is done automatically. Automatically, as you see there. We just did it just before. But what we see, the length of the lesion 11 millimeter, the diameter proximal 3.2, distal 2.6, and the side branch 2.5. Okay. So go live.
Branch, huh?
Go. Okay.
So while we're watching, we'll discuss this a little bit. This is a true bifurcation lesion for sure. Involvement of the osteum of both branches, proximal to the bifurcation. And it looks like just on the initial angiograms you took, there's a fair amount of calcification running right along the sort of inferior surface of the vessel. Does it look calcified to you guys there?
There is a little bit of, there is calcification at the level of the lesion, Not, let's say, not very important,
so
but there are,
Okay, so the decision here is whether to approach this right up front as a two-stent procedure or try to do it as a single stent, predilate both branches, maybe leave a protecting wire down the diagonal and stent the main channel with a drug-eluting stent, then go back to see what you can do to the side branch. But, there's a lot of disease right at the origin of the side branch, and I think it's going to be very difficult to get a satisfactory angiographic result on that.
I tend to agree with that. I think that this is a kind of case where the diagonal artery is so large and there is such a tight stenosis that just doing a balloon angioplasty will not be enough. So the probably a two-stent approach. The question is, how to do the two-stent approach, whether to use a culotte or crush or mini crush, or simultaneous kiss. It appears that the LAD proximal to the lesion is a fairly large vessel, and perhaps a simultaneous kissing stent may not be a bad idea here either. But I just think that the extent of the disease is so much at that lesion that it might not have enough room to put in two simultaneous stents in a double barrel fashion to have an optimal expansion. What do you think, Manish?
I think that the issues here are just what we were talking about. One, the calcification. Are you going to be able to adequately expand both the main lesion and the side branch? And I think either SKS or culotte is appropriate. But I agree with you, Raj, that it's a bulky lesion on both sides. It may be that once you can expand both, hopefully expand them appropriately, culotte is not a bad way. I agree. I don't think provisional stenting is the way to go for this caliber side branch and disease pattern.
Ramon?
Okay, so our strategy maybe let's say the side branch is not a small one. It's a 2.5, but it's not also a very big one, only 2.5. And what characteristic of the lesion is that it's very, very short on the side branch, and there is a lesion. Maybe we can you show again the image moving? Okay. You see, it's very, very short. So you know that it's near always our strategy. But this time it will be as because of the size and because of the shortness of the lesion, a one stent with provisional destenting strategy, if necessary. But we will do our best and try to convince you that with only one stent you can cover the ostium of a second. Of an ostium of diagonal without needing a second stent and avoiding too much metal and maybe the risk of go back live, please. Go back live.
Test.
Thank you.
Well, provisional stenting approach is certainly fine. The question is how. If you are going to just do the balloon angioplasty, what I would probably recommend is to use a cutting type balloon angioplasty to expand the lesion better. What do you think?
I think the calcification at in the main vessel and also the ostium of the side branch, pre-treatment with the bulking would be a good idea also. But I don't think you can get away with provisional stenting. I will favor once you reverse mini T stenting or mini crush in this type of lesion because the lesion and the side branch is relatively small.
Yeah, the lesion is really very short and maybe it's just due to the plaque in the main branch and let's say there is a price to pay when you put two stents. Which is the higher risk of stent thrombosis. So what he's doing at the moment is pre-dilating the main branch. It's Philippe Garot, my partner, who is working with me. Microscopy.
Murray, what do you do with this type of patients in terms of anticoagulation? Is this patient getting 2B3A inhibitor, or this is a patient on bivalirudin or heparin and Plavix?
No, we are not with 2B3A. He was loaded